expectation, I think CRS is more easier than lateral pelvic node dissection and stick centration. This procedure is more simpler than prior ones. And this is my work. As all of you, main operation is laparoscopic or robotic approach. And cytoreductive surgery is here because the number of patients is very small, but our center want to provide the best treatment for each patient, so we are keep going this procedure. Cytoreductive surgery is not like cytoreductive. It is like just the peeling of some layer. And for some part, if there is some invading tumor, we remove some part. But the most part is peeling peritoneal layer. So it's very simple procedure. And also HIPEC is more simpler than cytoreductive surgery. We just waiting time for completing the drug dropping. However, many surgeons are not doing this procedure, I know, because maybe they are has some fear like to the lateral pelvic node dissection or eccentricity, or they are very busy, or there are many patients. Currently, cytoreductive surgery and HIPEC are using like this category. CRS and HIPEC is main, and still the drugs are very limited. Mitomycin C and oxaliplatin. And recently, recent studies started to use irinotecan for HIPEC. And other approach is cytoreductive HIPEC and adjuvant EPIC, or cytoreductive and EPIC, and in some institution, actively evaluate about proactive as a adjuvant IV chemo. They use adjuvant HIPEC for locally advanced colon cancer. So these are guidelines, NCCN and ESMO, and the guideline contents has very slowly changed, quite different from the recent guideline for rectal cancer. And also they has a little bit different stance for HIPEC. The two guidelines actively recommend cytoreductive surgery, and NCCN guideline a little bit have passive for HIPEC, and ESMO still actively recommend HIPEC. And actually, IP chemotherapy was started with a similar period with IV chemotherapy. So IP 5FU was compared to surgery alone, and as you can see here, IP chemo showed survival benefit in patients with stage 2, and it was effectively controlled local disease. But in stage 3 patient, in this patient, systemic metastasis is main recurrence. So the IP chemo could not improve the control for systemic metastasis. So IP chemo is usually used for peritoneal to control peritoneal recurrence. This is one of the most important randomized control trial, initial randomized control trial. This study showed that cytoreductive surgery and mitomycin C HIPEC could improve survival for patients with peritoneal metastasis than IV chemotherapy alone. So after this randomized control trial, many surgeons started to actively use HIPEC and cytoreductive surgery. And this is a recent trial, different from the previous randomized control trial. They used the oxaliplatin HIPEC, and they could show very good result for overall survival. Median survival was more than 14 months. However, there was no difference between cytoreductive surgery alone and cytoreductive surgery and HIPEC. So, and however, in subgroup analysis, in patients with intermediate disease stage, there was a little benefit of oxaliplatin HIPEC after cytoreductive surgery. So now many surgeons who perform cytoreductive surgery and IP chemo perform interested in mitomycin C HIPEC, which is very old regimen but has effect on peritoneal control of colorectal cancer. So this is ongoing trial which want to compare cytoreductive surgery alone and cytoreductive surgery plus mitomycin C HIPEC. And their primary endpoint is peritoneal recurrence rate. And during the past many years, surgeons moved from EPIC to HIPEC. There is no well-known reason, but maybe the management or postoperative treatment is easier for HIPEC. And anyway, and this this study want to compare between EPIC and HIPEC, and the interim result was published, and there was no difference between EPIC and HIPEC. And there is another use of HIPEC for like adjuvant chemotherapy, and these two studies used oxaliplatin HIPEC for adjuvant intraperitoneal chemotherapy. And the first one performed interval HIPEC, and the second one performed oxaliplatin HIPEC after second look evaluation. However, these two trials failed to show the effect. This is another one, the recently published. They different from the previous studies. This study used mitomycin C HIPEC, and the indication was clinical T4 tumor, and they could show they could reduce the peritoneal recurrence when they used HIPEC. The overall survival was not different actually, but peritoneal recurrence could be reduced by using mitomycin C HIPEC. So as you already shown, after cytoreductive surgery and for adjuvant intraperitoneal chemotherapy, recently most surgeons use mitomycin C HIPEC. And this is another ongoing trial which want to compare to evaluate the adjuvant effect of adjuvant mitomycin C HIPEC. The indications are including T4 perforation and ovarian metastasis, which are well-known risk factors of peritoneal metastasis. In Korea, we have also limited numbers of hospitals which perform cytoreductive surgery and HIPEC, and our center is one of them. And we started very early. And currently, we use HIPEC with mitomycin C, and sometimes we use EPIC for very selected patients. And this is our cases. We introduced the HIPEC machine 2014. So before that, we only had could perform EPIC, and currently we moved to HIPEC because for EPIC we have to do management of patients for 5 years of 5 days after surgery. So it makes some workload. So we perform intraoperative peritoneal chemotherapy. And we performed several studies of our experience. Firstly, we want to evaluate the effect of intraperitoneal chemotherapy. So compare the patients who received CRS only and CRS plus EPIC. And the results showed, EPIC showed could improve overall survival, disease-free survival, and as well as peritoneal disease-free survival. And recently we also evaluated the role of intraperitoneal chemotherapy again, and we included EPIC and HIPEC. So as you can see here, patients who received cytoreductive surgery and IP chemo and systemic chemotherapy, the cancer-specific survival was highest. And if patient received only CRS or CRS plus systemic chemo, the survival was worse. And also we recently could compare between our prior regimen EPIC and HIPEC, and the number was limited, 88 patients in each group, and the overall surgical morbidity was a little bit higher in the EPIC group because maybe the reason may be prolonged exposure to chemotherapy. And however, overall survival and progression-free survival was not different. So if patient has risk factors of complications such as multiple resection of a bowel or multi-organ resection, EPIC can be risky for surgical morbidity. However, in patients without those kind of risk factors, we can provide HIPEC as well as EPIC, I think. And at our institution, as you know, we are very well specialized MIS centers. So we also provide MIS approach for this patient. So about half of patients receive laparoscopic cytoreductive surgery and intraperitoneal chemotherapy. And the indication is usually the maximum score is 10, and in very selected cases with higher than 10, sometimes receive laparoscopic approach for cytoreductive surgery. This is my video. Maybe you can see easier procedures than the excenteration or lateral peritoneal dissection. This patient was 48 years old, and he had clinically T4A and 2, and peritoneal metastasis was omental huge mass and rectovesical area. So I gave him 4 cycles of chemotherapy, and then the tumor and metastatic lesion all regressed. So we decided to perform operation. The port placement is similar to the usual surgery. And I performed the right hemicolectomy as usual, and here is omental mass. In this case, the patient has very huge metastatic lesion, but the number was very limited, so the laparoscopic approach was very easy in this case. And I removed this tumor without resection of without bowel resection. And yeah, I will skip. And then I moved to pelvic area, and this is another huge metastatic lesion, and there was small nodules around it. And my plan was slightly lateral side from user TME. So just to split off one layer with preserving the structures. If there is no reason, we do not remove the peritoneum, just on the area where the nodule is located. And this is left side. And the posterior is usually similar to TME. Yeah. And then in this case, the metastatic lesion invaded to the rectal wall, so I performed segmental resection of rectum. And this is another case. He was very young patient, had obstructive symptom by transverse colon cancer. And I performed the CT scan and PET CT scan, but there was no metastatic lesion, but regional lymph node metastasis was found on PET scan, but peritoneal, there was no metastatic lesion. So I want to perform extended lymph node dissection. So I injected ICG, as I showed you yesterday, and I could find lesional lymph node clearly during operation. And so, however, during the exploration, I found peritoneal metastasis here. So main was pelvic area and omental metastasis. So I decided to I changed my plan, and I performed transverse colectomy and peritoneectomy and HIPEC. And this is video. And I skipped the transverse colectomy, and there was several nodules, and already I split out the layer of peritoneum. And in this case, the nodule did not invade to any organ, just on the peritoneum. So I split up the peritoneal layer very carefully. The procedure is similar to the prior video. And the most important part when I do not perform bowel resection is here, peritoneal reflection area. So we have to discriminate what is bowel wall and where is the peritoneum. Here is rectum, and I removed visceral peritoneum from rectal wall. And then peritonectomy was completed. Okay. And this is the final view. And after peritonectomy, we perform HIPEC like this when we perform the laparoscopic approach. Sometimes we use retraction and semi-open method, and sometimes we use closed method, and just waiting for 19 minutes. And recently, we compared between laparoscopic approach, the safety, to evaluate the safety of laparoscopic approach. But there was no difference between patient survival between laparoscope group and open group. And recently, again, I could compare patient who received cytoreductive surgery and HIPEC. And the maximum score was 13, and the number was small, but there was no difference between two groups regarding overall survival and peritoneal recurrent survival and progression-free survival. In our hospital, the median overall survival of lab group was 34 months. And this is survival curve, and the overall survival result is similar to PROD7 study, and progression-free survival median is very short, but they could survive more than 3 years. And peritoneal disease control was quite well. So I would like to say, if you perform cytoreductive surgery, if patient is feasible, we have to provide IP chemotherapy. And EPIC and HIPEC can show similar effect, so it depends on the patient or surgery risk. And open surgery can be reduced to minimally invasive surgery if patient have limited peritoneal recurrence. Okay. Yeah. I will skip, and thank you for your attention.
Thank you, Dr. Soo Yeun. A very comprehensive presentation. Actually, you reviewed and show us all aspects of HIPEC, but I think it's time. Yes, thank you.
Okay.